Thanks for joining me today. It's always a special time to be part of PPMD, to be part of the PPMD family and community. I think it's great that we get to talk and share what we've learned. Today, I wanted to walk you through, DMD 101, but also then looking at the aspects of what we've learned over the last few years. So I'll give you an overview of PTC Therapeutics, who we are in general, what we do, and why this is important to us. So if you look at the content of the material that we'll have coming up, there's going to be information we'll share that's a little bit ahead of time. So there's a forward-looking statement, which just covers off on the information contained, related to the meaning of Private Securities Litigation Reform Act of 1995. You can see the details here. You can follow up if there's more information requested. So when we look at it, when we look at PTC, in general, PTC is a rare disease company. And we say rare disease, but when you have the condition, it's no longer rare. So what we look at here is PTC has multiple different things that we're doing. Our pipeline is full of different opportunities. And when I look at each of these, these opportunities, whether it's a splicing technology for spinal muscle atrophy, when we look at these different families, these are all representative of families like yours, patients like yours, people who are struggling with the conditions they have, and we're looking for better ways of treating them. So whether it's splicing technology or gene therapy or macromolecules, we're looking at any way that we can make lives better in this rare disease space. So now that we're dealing with this, now once families are diagnosed with DMD, clinicians are dealing with newly diagnosed patients, what we need to look at from a community standpoint is how do we researchers partner with the families and partner with the HCPs to really come to better outcomes for families. So when we think about it, in DMD, we've learned over the course of a number of years that early treatment with corticosteroids tends to lead to better long-term beneficial effects. So when you think about it, if you look at the continuum, when patients are really presenting with early signs and symptoms, this could be motor and speech delays, this could be gait problems, those are the times that we can begin to identify DMD as a potential diagnosis for these patients. So typically around 5, we see it very pronounced. We see Gower signs, so kids are having difficulty getting off the floor. This is a lot of times historically where steroids have been introduced. What we've learned over time is the earlier that we get steroids on board, the more benefit that patients tend to have. And that's kind of at the end of the day, early detection, early diagnosis, early treatment, and matching them up with the right treatment makes all the difference in the world. So when we see this, I think it's important for us to take a step back and just really begin to understand what's happening with the muscles. So when you think about it, DMD patients and families and clinicians recognize DMD as being the hallmark of lack of dystrophin. So what happens is these dystrophic muscles, or these muscles who lack dystrophin, will have a leaky muscle membrane. And the leaky muscle membrane creates a situation where the muscle acts as an antigen. So as the tissue is torn, then the immune cells react to this presence of the muscle antigen, releasing cytokines and chemokines, which triggers Th1, Th2, and B cells. So this inflammatory response really is the hallmark of what we're seeing in DMD. And so what happens is the M1 and M2 macrophage that you can see there in this illustration are signaling what happens, whether it's a constant inflammatory state or whether it's a muscle regeneration state. So in the M1 macrophage presentation, the muscle is constantly in this inflamed state. And what happens normally when you and I go to the gym, we have this inflammation after lifting weights, which is this M1 macrophage presentation, but then it switches to an M2, which builds the muscle stronger and thicker and better. But in DMD boys, the M2 macrophage doesn't really get triggered, in part because of interferon-gamma, because of other immune infiltrating cells. So what this means, to kind of put it in a little bit better diagram, a little bit easier to understand, is really what we're looking for is this balance. So the immune system is necessary to help repair and to defend ourselves and to keep infections out. But really what happens is muscle by itself isn't an antigen, but in DMD it does become an antigen. So what happens is the immune system, and more specifically T cells, identify the muscle tissue as the enemy. And so then it goes through, it tries to destroy that tissue, and over time, children lose functionality. So what we're trying to do is really restore balance. And the way that we're doing this in the immune system is we're taking the edge off the immune system, not getting rid of it altogether, but just downregulating the immune system to allow the muscle tissue to exist as long as possible and be as functional as possible. So you can see too little immune system relates to infections or in cancers in certain situations, in overexpression of the immune system. You get allergic reactions, you get autoimmune diseases, or you get this muscle degradation. So when we look at steroids and we look at what are our treatment options, so now we're at that point where we have to decide what we want to do. So when we look at the options right now in DMD are either prednisone or deflazacort. So deflazacort is the active ingredient in Deflaza. It's available on the market here as Deflaza. But prednisone there's no label for it. It's being used in an off-label fashion. So when you look at the molecules themselves, they're both steroids, which means they belong to a class of drugs called corticosteroids. And you can see from the structure, there are similar properties with regard to the way that the structures of the molecules are. But if you look at the end of the deflazacort molecule, the arrangement of bonds and the arrangement of other components and elements creates a very different response. So structurally, these drugs look very different. And functionally, we expect them to be very different as well. So when we go back to the immune system, and as I had mentioned before, interferon-gamma is one of these key immune signals. When we look at this, we understand that deflazacort and prednisone do have a differential effect on the immune system. So what this means long-term, we don't really know completely, but we do understand if we're trying to restore balance, there may be a benefit that we see because the drugs are working differently on the immune system. So what this tends to do is, as I mentioned before with interferon-gamma, so when interferon-gamma is high in patients, interferon-gamma will sit on an interferon-gamma receptor and it signals downstream for the body to do certain things. So one of the best ways to see this is to look at this in action. So if we think about this, at the top of this diagram, we have interferon-gamma sitting on the interferon-gamma receptor. When it's activated, when interferon-gamma is effective on that receptor, then it signals two pathways, the IKK beta pathway, JAK-STAT1 and 2 pathway. And what happens is by signaling IKK beta, we signal the production of NF-kappa B. So by the process of immunomodulation, by lowering interferon-gamma, we change that signaling pathway so we can interrupt the IKK beta to NF-kappa B pathway, so we can lower NF-kappa B, but we also can slow down the JAK-STAT pathway, which ultimately, these are two major inflammatory pathways in the body. So by modulating the immune system, we can directly affect the inflammatory pathways, ultimately leading to longer, better function. So as we downregulate interferon-gamma, we also change that M1, M2 macrophage presentation that I talked about a few minutes ago to create this regenerative process of muscle, or to at least continue to maintain the functionality. So what do we see in the real world? I know a lot of people are excited to talk about theoretical, but what do we see in the real world? So if we think about this, and we think about long-term studies like Synergy, which have been done looking over a 10-year period, understanding what happens in patients who are treated with steroids and patients who are not treated with steroids, what we see is patients who are exposed to steroids tend to have a slower progression of disease, which is important. So right now, until we perfect a cure, we're at the point of trying to slow down to maximize the function as long as possible. And that's why steroids have been seen to be beneficial at both, loss of functional declines, so slowing that, and also then loss of ambulation. And we know loss of ambulation is not the most important of all the functions. We understand that there are a lot of other things that are critically important to that. We do see this because, and we focus on this primarily because as we progress through, we know that we need to slow down this progression by avoiding things like loss of ambulation. So in a Synergy natural history study, they're looking at patients who are treated with steroids and patients who are not treated with steroids. And they look at then, what does this look like from a probability of loss of ambulation? So when they looked at things like deflazacort and prednisone, what they did see is they saw a difference. So they saw a difference in outcome with regard to delay of loss of ambulation. And so what this equated to over a long period of time is things like the ability of the loss of ability to stand, the loss of ambulation, and the loss of hand to mouth. All of these things were different between prednisone and deflazacort. So when we look at this and focusing more on some other aspects, this is newer data. This just came out this year. So in independent research, they were looking at this and trying to understand, do they see the same type of benefit? Do they see the same type of difference with outcomes with kids who are treated with steroids? And so what they see is in this particular trial, they see that there is a change in the difference in loss of ambulation, but they also then see scoliosis onset being different. So just as Synergy was a natural history study, this one is looking at data from Cincinnati Children's Hospital and looking at these kids followed for 11 years to see if there is a difference. And they do see that there are differences in scoliosis onset. So beyond the ambulation, there are other things like scoliosis and also then pulmonary function. So looking at pulmonary function, we know this to be an issue in later stages of DMD. So looking at this, they did see a difference in the functionality of the lungs in the kids treated with Deflazacort as compared to Prednisone. So again, this creates the idea that finding the right treatment early can make a difference in the long term. So one of the things that we have to look at and to be objective about is we do see benefit, but we also have to be aware of what side effects we see. So all drugs that are working, and I say working because if I don't see a side effect, I really wonder sometimes if drugs are working. But if we look at, if we look at all of the patients and we look at the side effect profile, typically what we see with corticosteroids is weight gain, cushingoid behavioral changes, growth delays, and cataracts. And there are differences between the two treatment regimes. So sometimes you'll see more cataracts potentially with Deflazacort as compared to Prednisone, but you may see more weight gain associated with Prednisone as compared to Deflazacort. So again, you have to consult your HCP, and physicians have to then have these discussions with families to determine what the right course of treatment is. But again, this is just kind of showing in clinical trials, the same thing was seen, that there are differences between the outcomes of patients, and you can look at then overall what types of side effects to be prepared for. So HCPs can have those discussions with families can have those discussions with HCPs, and they can partner together to understand objectively what the data say to make the best choice for each patient. So one of the things that's coming up, and I think people are interested in seeing, is a 4DMD trial. That study should be wrapping up and should be available at some point in time. So when they look at the different doses, whether it's Prednisone alternate dosing, whether it's Prednisone daily or Deflazacort daily, we've seen these data in other clinical trials. So those data points do exist the way they have been measured. So it'll be interesting to compare and contrast what is in the newer studies as well. So in closing, I really appreciate the opportunity to talk to you today. Really appreciate the opportunity to partner with PPMD. We do know that steroids are really here to stay even in future evolutions of treatments. As we replace dystrophin, there's still going to be likely a need for steroids to be on board to help with the immune response. But what we do see from what we've learned is Deflazacort and Prednisone are different. They have different outcomes, and the long-term benefit typically is different with Deflazacort as compared to Prednisone. So in closing, Deflazacort, as I mentioned before, is the same active compound found in plasma. So I really appreciate the opportunity to talk to you today. Thank you so much for everything you've done, and best luck in your treatment journeys.